Today's content is oxygen therapy with a focus on mechanical ventilator management. This content comes from Chapter 23 in your Clinical Nursing Skills and Techniques textbook. This is intended to be a basic introduction to mechanical ventilation. Mechanical ventilation is when a machine is used to move oxygen into the lungs and carbon dioxide out of the lungs. It is a life-saving therapy that is used for patients who have an inability to protect their airway or who have an illness that leads to respiratory failure. Mechanical ventilation also provides supportive therapy until a patient can ventilate, maintain adequate oxygenation, and or protect their airway. Some of the indications for mechanical ventilation include apnea or impending inability to breathe or protect one's airway, acute respiratory failure, severe hypoxia, and respiratory muscle fatigue. An artificial tube is required, such as an endotracheal tube or a tracheostomy tube. Collaboration often occurs with respiratory therapy. They usually set up the ventilator, assess the patient at regular intervals, and they are a really good resource because they have extensive knowledge of the respiratory system since it is their specialty. There are two types of mechanical ventilation. There is negative pressure ventilation and positive pressure ventilation. Negative pressure ventilation is a non-invasive form of mechanical ventilation. In this type of ventilation, a poncho or shell is fitted over the patient, and air is removed from between the patient's chest and the poncho or shell, which creates an intermittent negative pressure that allows the chest to pull outward, which reduces the intrathoracic pressure, resulting in inhalation. It forces the patient to inhale as oxygen moves from an area of higher atmospheric pressure to one of lower intrathoracic pressure. And you can see an example of negative pressure ventilation on the top right side of your screen. The bottom photo is of the iron lung. The iron lung was created in the late 1930s or 1940s to treat patients with polio. The patients were placed in a cylinder and negative pressure was applied. There are also portable machines that are used today for the chronic management of neuromuscular disease, injuries of the spinal cord, and central nervous system disorders. So just think of any illness where the innervation to the muscles of the chest wall and or diaphragm are affected, or the respiratory muscles themselves aren't strong enough to carry out the process of ventilation. The negative pressure from these machines assists the muscles of the chest and the diaphragm by actually pulling the chest outward, thereby giving the patient the extra help that is needed to physically inhale. And then exhalation will happen passively. The type of ventilation that we will mostly focus on will be positive pressure ventilation. It is the usual method of mechanical ventilation. With this method, positive pressure is used to inflate the lungs. The ventilator takes on the physical work of moving air in and out of the lungs, but not the physiological function. Therefore, the alveoli have to be functional and the blood flow to the pulmonary capillary bed has to be sufficient for gas exchange. Positive pressure ventilation maintains or improves ventilation, oxygenation, and breathing patterns. It requires an artificial airway such as a tracheostomy tube or an endotracheal tube, as well as humidification. Some of the potential complications of positive pressure ventilation are decreased cardiac output, aspiration, barrier trauma, ventilator-associated events, ventilator-associated pneumonia, bronchospasm, laryngeal trauma, and sinusitis. Decreased cardiac output can occur as the thoracic pressure in the chest rises from the positive pressure inserted by the ventilator. This can put pressure on the pulmonary vessels, which in turn will decrease cardiac output. Therefore, it is important to monitor the patient's cardiovascular status. So we would assess blood pressure, pulse, capillary refill, skin color of the patient, cardiac rhythm. If the patient's critically ill, they may also have a central line in place to monitor their central venous pressures as well. Altered level of consciousness, certain medications, and feeding tubes are some of the things that would put a patient at greater risk for aspiration. Therefore, it's important to keep the head of the bed positioned at 30 to 45 degrees. Barrier trauma is pressure-related trauma that can occur because of the positive pressure that is used to keep the airways open during inhalation and sometimes during exhalation. The airways and the alveoli can become damaged due to hyperventilation in situations and this can be seen in situations like pneumothorax. Ventilator-associated events are usually unexpected outcomes of a patient on a ventilator. To be considered an ventilator-associated event, the patient has to be on a ventilator for 2 days. Ventilator-associated pneumonias, which are a type of ventilator-associated event, is the leading cause of death among all healthcare-associated infections. It has a 20 to 50% mortality rate in patients receiving mechanical ventilation. Laryngeal trauma can occur during the endotracheal tube insertion. Sinusitis is possible due to a nasal route for intubation. So if the patient has the endotracheal tube inserted via the nair, there's a possibility for sinusitis, and it's thought that this is related to obstruction that can be caused from the tube that can lead to an accumulation of fluid in the sinus cavity, which in turn can lead to inflammation. There's also the possibility of biofilm formation within the endotracheal tube, which increases the risk for colonization of bacteria. A patient should only be on a ventilator as long as medically necessary and weaned as soon as possible because the mortality rate increases the longer someone is on a ventilator, and it's harder to wean them the longer they're on as well. There are many possible ventilator settings. We are only going to cover the basic settings. The first setting that we will look at is tidal volume. Tidal volume is the volume of air that is transported in and out of the lungs with each breath. It is between 6 to 12 milliliters per kilogram of body weight. The number is lower in ARDS and can be lower depending on the patient's overall condition. The second setting that we will look at is respiratory rate, and it is usually set at 10 to 16 breaths per minute. The ventilator can be programmed to deliver all of the patient's breaths, or there are some modes in which the ventilator will allow the patient to breathe spontaneously in between mandatory breaths, or the patient might actually initiate the breath and then the ventilator will take over from there. The next setting is the fraction of inspired oxygen, or FiO2, which is the concentration of inspired oxygen. This setting may seem familiar to you from your studies on different oxygen delivery devices. Remember that a nasal cannula delivers an FiO2 of 24 to 44% on 1 to 6 liters per minute, and a simple face mask delivers an FiO2 of 35 to 45% at 6 to 12 liters per minute. The overall goal is to use the minimum FiO2 to maintain a PaO2 greater than 60 or an oxygen saturation greater than 90%. Generally, the patient may be started out at a higher FiO2 and then titrated down. The last setting that we will focus on is positive end expiratory pressure, or PEEP. It is the amount of positive pressure that is applied during exhalation, during the expiratory cycle, to keep the alveoli open and improve oxygenation. 5 centimeters of water is typical, but some patients, like those with respiratory failure, may need higher levels. And there is a link on the bottom of the screen that will go over some of the ventilator settings in more detail if you would like to view that on your own. Next, we will look at the modes of positive pressure ventilation. Modes are pre-programmed methods of ventilation. The mode that the provider prescribes for the patient will depend on how much work of breathing the patient can and should exert. So questions to have in mind are, how functional are the muscles of the chest wall and diaphragm, because they play a huge role in being able to physically inhale, and can the patient or should the patient exert the energy that is required to breathe? If the patient is severely ill or just needs to rest, the ventilator may do all of the work. The mode also depends on the patient's respiratory drive, which is controlled by the respiratory center and the medulla, the brainstem. Remember that the respiratory center responds to chemical signals such as pH changes, PaCO2 changes, and PaO2 changes, and in addition to mechanical signals that are activated by things like irritants or muscle stretching or alveolar wall changes. The respiratory drive of the patient dictates the respiratory rate and the tidal volume. So if the respiratory center is triggered under certain conditions, the patient may breathe faster or may breathe slower. The mode that the provider selects also depends on the arterial blood gas results or ABG results. This will drive the mode as well. So as you can see on the screen, there are several modes. Your book has a chart with about 8 different modes. We are going to focus on main classes. The modes are divided into volume ventilation and pressure ventilation. With volume ventilation, there is a predetermined or preset tidal volume that is delivered with each breath. Volume ventilation is further divided into controlled or assisted. With controlled volume ventilation, the patient receives a set number of breaths at a set volume. The ventilator does all of the work, and with assisted volume ventilation, the ventilator and the patient share the work of breathing. The patient will initiate or start the breath, and then the ventilator will deliver the preset tidal volume at a preset frequency or rate. In volume ventilation, the pressure at which the volume is delivered varies with each breath depending on how compliant the lungs are. Remember that compliance refers to the elasticity of the lungs. Decreased compliance makes the lungs harder to inflate, and conditions or diseases that result in stiff or restrictive lungs are things like pneumonia, pulmonary fibrosis, or pleural effusion. However, with volume ventilation, the tidal volume is going to be the same with each breath. The pressure at which that tidal volume is delivered is the thing that will vary. In pressure ventilation, positive pressure is applied to the airway during inspiration in a patient who is spontaneously breathing. So the patient has to be breathing on their own. This will just add some extra pressure. The level of positive airway pressure, which is considered peak inspiratory pressure, is preset or predetermined. The tidal volume will vary based off of the inspiratory pressure the ventilator provides and the airway or lung compliance. This mode of ventilation is often used in weaning the patient off of the ventilator or as a supplement to other modes. The patient controls the rate, so the patient will control when they breathe, and they also control the tidal volume. So the patient is going to, it's important to monitor the pressure for hypo or hyperventilation. to review, with pressure ventilation, the, the patient receives a preset amount of pressure with each breath that they initiate. The tidal volume will vary based on the amount of positive pressure that is used and the lung compliance. On the bottom of this slide, you will see other types of mechanical ventilation. There are some combinations that are used. You don't have to be familiar with those, but just some examples of different modes that you will see. Mike. Positive and expiratory pressure, or PEEP, is more of a ventilator setting instead of a mode. It is similar to CPAP, which many of you may be familiar with, except the pressure is not continuous. With PEEP, positive pressure is applied to the airway during exhalation, which increases lung volume and functional residual capacity so that oxygenation is improved overall. The benefit is the effect that it has on the alveoli. It will open collapsed alveoli and prevent open alveoli from collapsing. PEEP is contraindicated or used with caution in patients with highly compliant lungs. These are lungs that have increased elasticity, which might lead to overstretching and damaging of the alveoli. In the case of hypovolemia, a patient may have decreased cardiac output due to decreased fluid volume. If that patient is prescribed high levels of PEEP, that positive pressure can increase thoracic pressure within the chest, which can put pressure on the pulmonary vasculature, further decreasing cardiac output. Therefore, if PEEP is needed, it will be prescribed at low levels and the patient's cardiovascular status would be monitored very carefully. Since PEEP increases lung volume and functional residual capacity, the FiO2 can often be reduced. So that is also another benefit of using PEEP. Next, we are going to look at some forms of positive pressure ventilation that can be invasive or non-invasive. The first one is continuous positive airway pressure, or CPAP, in which positive pressure is continuously applied during respiration. So there's positive pressure during inspiration and expiration. It requires a tight-fitting mask, or it can be applied through an endotracheal tube or a tracheostomy tube. It is commonly used in obstructive sleep apnea. Caution has to be used if the patient has any cardiovascular compromise, because there is a potential for the positive pressure to affect cardiac output. It causes a significant increase in intrathoracic pressure. CPAP might not be as comfortable for the patient depending on the amount of pressure that is applied by the CPAP machine, because the patient will be required to exhale over that pressure that is exerted during exhalation. Another form of positive pressure ventilation is bilevel positive airway pressure, or BiPAP. There are two different levels of positive pressure in this case, usually a higher inspiratory pressure and a lower expiratory pressure with the addition of oxygen. This type of positive pressure ventilation may be more comfortable for the patient because the level of pressure during exhalation can be adjusted to lower levels so that the patient doesn't have to work as hard to exhale over the expiratory pressure. BiPAP can be invasive, given through an artificial airway, such as an endotracheal tube or tracheostomy tube, or it can be non-invasive and given through a tight-fitting mask, a nasal mask, or nasal pillows. It is often used in patients who have COPD with heart failure, in cases of acute respiratory failure, and in sleep apnea. What does the evidence or research say about how we can best care for patients on ventilators? As discussed earlier, ventilator-associated pneumonias are the leading cause of death among all healthcare-associated infections. So bundles or interventions were created to help decrease the rates of ventilator-associated pneumonias. Some of these interventions include good hand hygiene, checking endotracheal tube cuff pressures every 2 hours and maintaining them at 25 to 30 centimeters of water. Respiratory therapy may do this, or this may be the nurse's responsibility. The head of the bed should be maintained at 30 to 45 degrees to prevent aspiration and help with oxygenation and ventilation. The patient should be on DVT prophylaxis or PUD, peptic ulcer disease prophylaxis, with something like an H2 antagonist or PPI. There should also be daily sedation interruptions to assess the patient's readiness to be extubated. There needs to be oral care at a minimum of 4 times a day. Some facilities may require more frequent oral care. This will reduce the risk of ventilator-associated pneumonia, which can occur when a patient aspirates oral secretions by keeping the mouth cleaner. A soft bristle toothbrush is used to brush the teeth, the tongue, and the oral mucosa with chlorhexidine at least twice a day. A water-based moisturizer is used on the lips and oral mucosa every 2 to 4 hours. Some facilities may require the use of 1.5% hydrogen peroxide solution every 2 to 4 hours. Just remember that alcohol-based products are not used because they have drying properties on the mouth or anywhere that it's placed. Another intervention is subglottal suctioning. So patients with endotracheal tubes may be required to have subglottal suctioning. This is suctioning that occurs above the cuff of the endotracheal tube. The patient must have a special type of endotracheal tube that has ports that will allow for this type of suctioning to occur. Lastly, the patient should be repositioned every 2 hours to help mobilize secretions, allow for maximum chest expansion, and minimize the effects of immobility. The evidence also shows that adult patients often remember and report feelings about their experience while being on mechanical ventilation. When a patient is on mechanical ventilation, even though communication is often impaired, you want to talk to your patient as if they are responsive. They may still be able to hear you even if they are sedated. So still take the time to introduce yourself, briefly explain what you're doing while you're in the room, because you just never know if they can hear you or not. And also keep in mind that all patients on mechanical ventilation may not be sedated. They may be mildly sedated, or the patient may be fully awake. So you still want to, even though they may not be able to talk back to you, you want to develop a method of communication that will work for you and the patient and the caregiver. Adult patients who are mechanically ventilated often report feelings of fear, disconnection, impaired body image, feelings of concern in caring from healthcare providers or lack thereof. So just to make sure that you are thinking about how to communicate with these patients and don't just treat them as they're just a warm body. You want to continue to provide communication and let them know what's going on, because again, they may be able to hear what you're saying. Now we will focus on the assessment portion of caring for a patient on a mechanical ventilator. A respiratory assessment is required. This includes respiratory effort, chest rise and fall for symmetry, auscultation of breath sounds, listening for adventitious breath sounds, assessment of oxygen saturation, and counting respirations. A cardiovascular assessment is also required, which includes blood pressure, pulse, heart sounds, patient color. It may also often include cardiac rhythm. We will inspect the mouth and surrounding skin. If there is an endotracheal tube in place, there is a risk for increased pressure on the mouth, or if it's in the nares, on the nares. If there is a special tube holder or tape is used, you would want to also check for tube placement. Tube placement is assessed by checking the centimeter markings on the tube. The depth should be noted in the patient's medical record, so that's something that you would want to look for ahead of time. You would also want to assess for signs and symptoms of advertent tube dislodgement or complete extubation. Some signs and symptoms would be vocalizations by the patient as air flows up and over the vocal cords. Other signs and symptoms may include only auscultating breath sounds on one side of the chest, only visualizing movement of the chest on one side, decreased oxygen saturation, decreased pressure readings on the ventilator, changes in endotracheal tube depth according to the markings on the centimeter markings on the tubing, and changes in capnography, which is used to measure carbon dioxide levels. And we'll go into this in greater detail on the next slide. Ventilator settings would also need to be assessed to make sure that the ventilator is set appropriately. Ventilator alarms would need to be assessed to make sure that they are actually on, as well as the cardiac alarms. End-tidal CO2, which is the amount of carbon dioxide in expired air, needs to be assessed. Normal values are 5 to 6%, which are equivalent to 35 to 45 millimeters of mercury. It is measured by capnography. The image on the top shows an end-tidal CO2 detector. The middle image shows what the waveform might look like. End-tidal CO2 is used to check for correct placement of the endotracheal tube or tracheostomy tube. Another thing that we would need to assess would be cuff pressures, which again should be maintained at 20 to 25 centimeters of water. Actually, with that cuff pressure, let's use the parameter that is in the ventilator-associated pneumonia bundle. And with that, we will use 25 to 30 centimeters of water for the cuff pressure. So just get rid of the 20 to 25 and add 25 to 30. Okay. Cuff pressures that are too low can lead to aspiration of oral or gastric secretions, and pressures that are too high can damage the mucosa of the trachea. Airway patency is another thing that needs to be assessed. And with this, you will look at the patient's need to be suctioned. If the patient is on a ventilator, indications for suctioning would be a saw-tooth-like pattern in the pressure and tidal volume indicators, increased peak inspiratory pressure or decreased tidal volume due to obstruction, decreased O2 sat, visible secretions in the airway, inability to cough effectively, or suspected aspiration. Arterial blood gas levels would also need to be assessed, and the provider would order these at certain intervals. The arterial blood gas, or ABGs, assess pH, arterial oxygen, arterial carbon dioxide, and arterial oxygen saturation. They give good information on the patient's oxygenation and ventilation status. You also want to assess communication. And as I mentioned before, some patients are sedated, some patients are lightly sedated, and some patients may be fully awake. So just make sure that you find a form of communication that works for your patient. You want to always let them know what you're doing and who you are, and just explain what you're doing in simple, concise terms. Something that you want to keep in mind when needing to troubleshoot mechanical ventilation is alarms. You never want to ignore alarms. You want to know which one it is, if it's high pressure or low pressure or whatever it happens to be. And then you would want to tend to the patient before the machine. So assess your patient, then the machine. Um, you want to just remember that alarms are there to alert the staff and let them know that the patient is experiencing a potentially dangerous situation. So alarms should never be silenced unless you are actually in the room with the patient, and never silence them for more than 2 minutes at a time. Nurses in the ICU often experience what's called alarm fatigue. It gets to the point to where they hear so many alarms that it kind of gets drowned out, which is a very dangerous thing because it's kind of like your baby crying when parents sometimes get to a point to where the baby's crying, they don't even really hear it anymore. So you want to avoid alarm fatigue and just to be alert and aware and always check the patient first, then look.
There are 6 alarms that we are going to cover. The first one is the high pressure alarm limit. It is triggered by a sudden increase in airway pressure. Some of the possible causes are coughing, airway plugging or excessive secretions, changes in patient position, pneumothorax, incorrect endotracheal tube positioning, kinked ventilator circuit or the tubing that goes from the patient's endotracheal tube or tracheostomy tube to the ventilator machine, excessive water or condensation in the ventilator circuit, the patient biting the tube, the patient breathing against the ventilator or fighting the ventilator, or either ventilator malfunction. And some of the nursing interventions would include suctioning the patient first off, trying to reposition the patient, verifying the placement of the endotracheal tube, draining the condensation from the circuit or tubing, unkinking the tubing if it's kinked, inserting a bite block if the patient's actually biting the tube, getting an order for a sedative if needed if the patient's fighting against the ventilator, and notifying the healthcare provider, of course, if the interventions are unsuccessful or if you need an order for any intervention that you don't have. The low pressure alarm is triggered if there is decreased peak airway pressure. So there is low pressure within the airways. This can happen if the patient is disconnected from the ventilator, if there's a leak in the ventilator circuit or the tubing, if the endotracheal tube is displaced into the pharynx, if the cuff is not inflated properly on the endotracheal tube or tracheostomy tube. It can also happen if the patient's lung compliance has improved or if the patient has a decrease in the amount of secretions that they have been producing. So with this, nursing interventions include checking the ventilator circuit or tubing for disconnections and fixing those connections, tightening them, assessing cuff pressures as well to make sure that the patient has an appropriate cuff pressure. The next alarm that we will look at is apnea. Some causes of apnea are respiratory arrest, over-sedation, changes in the patient's condition, and a loss of the airway, either total or partial extubation or dislodgement. The nursing interventions include providing breaths via a self-inflation resuscitation bag, reversing and disconnecting sedative medications, preparing for re-intubation if the tube is dislodged, and if it's dislodged and the patient still needs the tube to be in place. You can also assess the placement of the tube by looking at the centimeter markings. The next alarm is change in minute ventilation or tidal volume. This can be caused by a leak in the endotracheal tube cuff if the patient stops spontaneously breathing, or some of the other conditions that might cause a low or high pressure alarm. And then nursing interventions for that would include checking the cuff pressure or seal and evaluating the patient. The next alarm would be increase in respiratory rate. Some of the things that might cause a patient's respiratory rate to increase would be anxiety, increased metabolic demand, as well as hypoxia. The nursing interventions for that include reassuring the patient that you're there and you're going to try to provide the best possible care. You would assess their vital signs, the temperature, the pulse oximetry, cardiac rhythm. And the last alarm that we will look at that's not visible on your screen would be ventilator inoperative or low battery. In this case, what we would do, well, first of all, it is caused by equipment malfunction or if the ventilator is actually not plugged in. And the nursing interventions include plugging in the machine, notifying the respiratory therapist, and providing breaths via a self-inflating resuscitation bag if necessary.